Thank you very much. It's a pleasure to be with you this evening. Thanks for joining to hear a little bit about how to keep your heart healthy. So, I'm going to do a general review about preventive cardiology. It's really impossible in 30 minutes to cover everything, but hopefully, we could also get some of your questions answered during the second half of the program. So, as Jess said, I'm Dr. Wendy Post, and I am a professor of cardiology, and I specialize in prevention, and I'm part of a larger group at the Ciccarone Center for the Prevention of Cardiovascular Disease. And I hope that you enjoy the program. So, I wanted to first start with something that you probably know that heart disease is the number one cause of death. And that is followed by cancer and then accidents and stroke. And most people are not really thinking as much about their risks for cardiovascular disease as they are thinking about their risk for cancer, which is also, of course, very important. But there's a lot we know about ways to reduce your risk for developing heart disease, and we'll review some of that today. Going to start by telling you a little bit about what a heart attack is and a little bit about the heart. So this is a picture of the heart, obviously. These are the coronary arteries, which are the arteries that supply blood to the heart muscle. The heart is a muscle that requires oxygen, and the oxygen is supplied by these arteries we call the coronary arteries. What happens is fatty deposits called plaque build up in the walls of the coronary arteries. And this actually starts at a pretty young age. And the plaque develops and increases over time as we get older. And if you have more cardiovascular risk factors, it advances more rapidly. And then if the plaque becomes unstable, then it can rupture. And what happens is the cholesterol and fat inside the plaque then comes out into the artery. This is the blood in the artery, and it can cause a blood clot, which is called a thrombus. And this is supposed to be a picture of a thrombus or a blood clot. And if the blood clot then completely blocks the heart artery, which is what this shows, then you can have what's called a myocardial infarction or a heart attack. And what happens is when the artery is completely blocked, then the heart muscle is not getting oxygen and the heart muscle actually dies. And so the sooner you get to an emergency room and get that artery opened up in the catheterization lab, or depending on where you live with medicines that are clot busters, then the less heart muscle dies. So you want to get to the emergency room right away if you were having a heart attack. What we're going to talk about today is how to prevent a heart attack, or to prevent angina, which is when you have a narrowing that doesn't completely block the heart artery. So what are the signs and symptoms of a heart attack? So if you have these signs or symptoms, you want to call 911 and get to a hospital right away. So typically we see this picture of here is a person who's sort of clutching his chest. So it's an uncomfortable pressure, squeezing, fullness, or pain, generally in the center of the chest. It lasts more than a few minutes or goes away and comes back. Sometimes the pain will be in one or both arms, generally the left arm, but it could also radiate to the back, the neck, the jaw, or the stomach. Might be accompanied by shortness of breath, with or without chest pain, or other signs such as breaking out in a cold sweat, nausea, or lightheadedness. But by far the most common symptom of a heart attack is chest pain or discomfort, pressure. It's usually not a sharp stabbing pain, but more like a pressure sensation. But there are lots of other things that can cause chest pain. Some of them are listed here. I don't know why they called it GORD, but this is GERD, which is reflux, or ulcers, esophageal spasm, gallbladder disease, having an inflammation of the joints between the ribs and the sternum, pleurisy, which is an inflammation of the lining around the lungs. Lots of different things can cause chest pain. But sometimes you can't tell if it's coming from your heart unless you go to an emergency room. So we're going to talk today about risk factors. So there are risk factors that can be managed, and there are risk factors that you can't control. So you can control or treat these risk factors with lifestyle changes or medications, such as high blood pressure, smoking, high blood cholesterol, lack of regular physical activity, obesity or overweight, and diabetes or prediabetes. But factors that you can't control are advancing age, postmenopausal status in women is also a risk factor. Men tend to develop heart disease 10 years earlier than women, and women tend to get heart disease most often after menopause, but that certainly isn't a rule, and there are young women who have heart attacks as well. We're learning more and more about the importance of genetics and heredity and a family history of heart disease. And we generally consider premature coronary disease as a family history. So if your mother or father developed heart disease in their 80s or 90s, that usually isn't considered a risk factor. And we'll talk a little bit about disparities in race. And certainly if you've had a prior stroke or a heart attack, then you're at increased risk for having another stroke or heart attack. So I'm going to use this format, which was developed by the American Heart Association. It's called Life's Essential 8, and it identifies 8 of the most important factors for cardiovascular health. 4 of them are considered health behaviors, and 4 are health factors. So if you improve your Life's Essential 8, it isn't just good for your heart, it's also good for your overall health and well-being. And there are lots of resources on the American Heart Association website. So feel free to look through those websites. They have patient-specific infographics, they call it, but a lot of information about Life's Essential 8. So there are 4 key health factors. Blood pressure. You generally want your blood pressure to be less than 120/80. Lipids, so blood cholesterol or triglycerides. We're going to talk a little bit about lipoprotein little a. Here they talk about non-HDL cholesterol, and we'll talk about what that means. And it says your non-HDL cholesterol should be less than 130, but this really depends on your cardiovascular risk. And then healthy weight, we'll talk about a body mass index. And so having a BMI less than 25 is normal. And then blood sugar, so no history of diabetes, and a fasting blood glucose of less than 100, or a hemoglobin A1C less than 5%. So this is ideal. There are 4 health behaviors: no smoking or vaping, adequate sleep, getting 7 to 9 hours of sleep per night, a healthy diet, we'll talk more about that, adhering to a DASH or Mediterranean diet, and physical activity, very important, 150 minutes or more of moderate intensity aerobic activity, or 75 minutes of vigorous aerobic activity per week is what's generally recommended. So we'll start by talking about how to manage blood pressure. First, you want to understand the readings. So blood pressure is typically recorded as 2 numbers written as a ratio. The top number is the systolic blood pressure, and the bottom number is the diastolic blood pressure. So years ago, for some of the older people in the audience, we used to concentrate more on the diastolic blood pressure. And it was felt that the systolic blood pressure was less important because it goes up with aging. But now we know that actually the systolic blood pressure is very important, and you want to have both your systolic blood pressure and your diastolic blood pressure controlled. As we get older, the blood vessels get stiffer, and the systolic blood pressure tends to go up, and the diastolic blood pressure tends to go down. So what is a normal blood pressure? And these keep changing. So this is the latest blood pressure guidelines, which was developed by the American Heart Association, the American College of Cardiology, and other societies with a consensus among experts. And so what we consider normal here in green is a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. Elevated is between 120 and 129 and less than 80, whereas stage 1 hypertension, high blood pressure, is now 130 to 139 or 80 to 89, and stage 2 hypertension is 140 or higher or 90 or higher. It used to be a few years ago that hypertension was greater than 140 over 90. Now it's greater than 130 over 80. And then there's severe hypertension, greater than 180 or greater than 120. And if you have symptoms such as those listed here and a very high blood pressure, then that's considered a hypertensive emergency. And then you need to go to the emergency room. So it's important to consider various ways of monitoring your blood pressure. It's generally recommended that you have your blood pressure monitored in a physician or practitioner's office, but also have home blood pressure monitoring. And home blood pressure monitoring is very helpful because some people have an entity called white coat hypertension. Even if you're not wearing a white coat, people get it when I'm wearing my red coat also. And that way you can differentiate people who have high blood pressure only in the doctor's office. But realize that if you're monitoring your blood pressure at home, either with home blood pressure monitoring or ambulatory blood pressure monitoring, that actually your home blood pressure monitor goal is a little bit lower than what the office blood pressure is. What's really important is that you use the home blood pressure monitor correctly and also in the office. And you may notice sometimes when you go to the doctor's office that they're not necessarily following these directions. But before you measure your blood pressure, no smoking, no caffeinated beverages, alcohol, or exercise for 30 minutes prior. Most important is exercise. So I often see patients come in and show me, this was my blood pressure at the gym right after I finished exercising. That's less important. You want blood pressure when you've been sitting and resting for a while. So you want to use a validated device with the correct cuff size. And there's this website now called Validate BP where you can check to make sure your blood pressure device is a validated device. Often we use a device manufactured by Omron, and we're not recommending wrist monitors at this point, but these monitors that are on your arm. You want to make sure you don't have to go to the bathroom, and importantly, sit quietly for more than 5 minutes and do not talk. So you don't want to go find your blood pressure monitor in another room, go sit down and then check your blood pressure. You want to have been sitting for at least 5 minutes. It needs to be quiet. I have my blood pressure monitor next to the couch, and sometimes after I've been sitting for a while and I think, oh, I feel nice and relaxed now, I'm going to check my blood pressure. You have to be in the right position. Sit upright with back supported, feet on the floor, legs uncrossed. Rest your arm comfortably on a flat surface at heart level and wrap the cuff on your bare skin above the bend of your elbow, not over clothing. And often this is done incorrectly in the doctor's office. You want to stay relaxed, do not talk. Take at least 2 readings 1 minute apart. So often the first reading is higher than the second. So you might want to take, at least 2 or 3 readings in order to get an accurate measurement, and record all the results and share them with your healthcare professional. So we're going to talk about some ways that you can control your blood pressure. So if you're overweight or obese, you want to try to lose some weight, and a first initial goal would be to lose 5% of your body weight. So if you weigh 200 pounds, that would be losing 10 pounds. And you want to follow a heart-healthy eating pattern, such as the DASH diet, which we'll talk about, and limit your sodium intake. So if you're have a high sodium intake, that can affect your blood pressure. So you don't always have to count the amount of sodium in your diet, but look for low sodium alternatives, such as if you get tomato sauce to put on pasta, there are low sodium alternatives. And this is class 2, means it's less clearly proven, but there's more and more data about using salt substitutes, especially ones that are potassium based. And what's more strongly supported by research is having a diet that's high in potassium, unless you have kidney disease, and then you have to limit potassium. But generally, fruits and vegetables have a lot of potassium in them. And you want to limit alcohol intake. Regardless of whether you have hypertension, there's more and more information about the benefits of abstaining completely from alcohol. An oncologist recently told me that the oncologists say there's no amount of alcohol that's considered safe anymore. So we used to say less than one a day for women, less than or equal to, and less than or equal to two a day for men. Now I tell my patients, just try to do it out without it if you can. And if you're drinking every day, if you were to reduce your alcohol intake, not only does it help with your blood pressure, but it helps with weight loss because many of the things that we drink have a lot of calories in them. And exercise, structured exercise program, aerobic exercise, dynamic resistance, isometric resistance, and less clearly supported by evidence, but the importance of stress reduction, which clearly is pretty difficult to do, but more and more information about transcendental meditation and slowing your respiration. So sodium, the AHA recommends your sodium intake to be less than 1,500 milligrams a day. Leading sources of sodium are processed and packaged foods and restaurant foods. When I go to a restaurant, I ask the server to tell the chef not to add any salt. I'm so used to a low sodium diet that sometimes I go out to eat and the food is just so salty I don't like it. So often you get a lot of salt added to your food in restaurants. These are foods that tend to have a lot of sodium in them. It's not just the sodium the salt that you add with a salt shaker, but breads and rolls have a lot of sodium, pizza, sandwiches, cold cuts, soup, burritos, and tacos. So you want to try to limit that. All right, we're going to change topics now to cholesterol. So what is cholesterol? It's a fatty substance in your blood, and too much can clog your arteries and make a heart attack or stroke more likely. We calculate your total cholesterol by measuring your triglycerides, which need to be measured fasting generally, divided by 5, your HDL, which is generally considered the good cholesterol. In general, the higher the HDL, the lower your risk for heart disease. And then we calculate the bad cholesterol, which is the difference between the total cholesterol minus the triglycerides divided by 5 and the HDL. I did mention non-HDL cholesterol, which is the total cholesterol minus the HDL. And that's a way of just capturing what we call the atherogenic lipoproteins, which are the components within the lipoproteins that are more likely to lead to atherosclerosis or plaque or heart attack. So I wanted to mention briefly about lipoprotein little a or LP little a. You might be hearing more and more about this. This is a genetic risk factor for heart disease. It's a type of lipoprotein, but it's almost completely controlled by your genetics. So you tend to inherit it from your mother or your father. And we're learning more and more about how high LP little a is associated with a very strong history, a very strong risk for heart attack, stroke, peripheral arterial disease, also aortic stenosis, a valvular heart disease, and other heart conditions. What's exciting is that there is current research now looking at the effects of lowering LP little a. There are new medications that have just recently been developed that can dramatically lower LP little a. And there are clinical trials now underway where people with heart disease get randomized to lowering of LP little a versus a placebo. We're anxiously awaiting the results of those clinical trials to see whether these medications will be approved for use in our patients. So stay tuned. So what can you do to control your cholesterol? So you can eat a heart healthy diet, get regular exercise, lose weight if you're overweight. Often you will need medication. You don't want to smoke and stay on top of other risk factors. So we'll talk a little bit more about medication. So the most frequently prescribed medications are statins. And the common ones these days are atorvastatin and rosuvastatin, which are both available in generic formulation, so they shouldn't be too expensive. And they pretty dramatically lower risk for heart attack, death from heart disease, and generally all-cause death by 20 to 40%. This has been proven in multiple randomized controlled trials. So this is sort of our first line of therapy. There are some people who don't tolerate statins. The most common side effect is muscle pain or discomfort. And when you stop the statin, it generally goes away. Sometimes, if you have that side effect, you can try a different dose or a different statin and work with your physician to try to find a statin formulation and dose that will work for you. Very rare is muscle injury, what we call rhabdomyolysis, which is uh, most often seen if somebody's taking a high dose of a statin and then another medication that interacts with it and raises the blood levels of the statin. So it's important when you get a new medication to check with the pharmacist to make sure it doesn't interact with your statin. And then you may have heard that statins can increase your glucose. So there is an increased risk for new diabetes, but it's mostly people who just kind of cross the threshold. So people who have a glucose that is borderline and then it increases by a couple of points and then now they have a diagnosis of diabetes. But despite that, it's very clear that taking statin medications reduces the risk for heart attack and coronary disease. Statins, depending on which one you use and how high a dose, can reduce cholesterol by up to 55%. Often people will need an additional medication added, such as ezetimibe, which will lower cholesterol by 20 to 25%, can be used instead of a statin if you don't tolerate statins or in addition to a statin in order to get to your LDL cholesterol goal. Your LDL cholesterol goal is really determined by your cardiovascular risk. And we have new risk equations called the prevent risk equation that your physician will use to calculate your risk to determine how aggressively your LDL cholesterol should be treated and what your LDL goal is. Often the LDL goal is going to be less than 100, or if you're high risk or have heart disease, less than 70, or sometimes less than 55. A newer medication is bempedoic acid, which also lowers cholesterol by about 23%. And then the newer kids on the block are the PCSK9 inhibitors, and these are medications that are generally given by injection, although there's a new formulation that is in pill form. And these can dramatically lower LDL cholesterol. So these are often used in people with very high LDL cholesterol with or those who don't tolerate statins. We're going to change topics now to how to manage your blood sugar. So you want to make sure that your fasting glucose is normal, which is less than 100. If you have a fasting glucose between 100 and 125, that's what's called impaired fasting glucose or prediabetes. And people with prediabetes are at increased risk for developing diabetes in the future. And if your glucose is greater than 126 or higher, then you have diabetes and at increased risk for heart disease or stroke, and will need to be treated even usually with medications unless it can be controlled with diet and exercise. And another way of diagnosing diabetes is with an A1C, which is a measurement of sort of the average cholesterol over 3 months. So you want to make sure that if you're overweight or you have high cholesterol or hypertension, that you're following a healthy diet. So the diet that we generally recommend is called the DASH eating plan, and it lowers LDL cholesterol and also lowers blood pressure. And this diet, you want to eat more vegetables, fruits, whole grains, which are generally not white carbs, but carbs that are generally not white, like whole wheat bread or brown rice. And you want to eat fat-free or low-fat dairy. You want to limit fatty meats and whole milk or full-fat dairy. You also want to increase your intake of fish, poultry, beans, nuts and seeds, and vegetable oils. You want to limit or eliminate sugar-sweetened beverages, sweets, and limit sodium intake. So that's the DASH diet. We also recommend the Mediterranean diet, which is very similar. It's light on meats and sweets, high on fruits and vegetables, beans, legumes, whole grains, fish, nuts, and olive oil. And then a vegetarian diet is also a very healthy diet for those who can follow it, which is a dietary pattern that cuts out meat and in some cases seafood and dairy. Another important part of Life's Essential 8 is to be more active. So you want to get 150 minutes of moderate aerobic activity, walking, dancing, gardening a week, or 75 minutes of vigorous aerobic activity, such as running, swimming, or jumping rope. And this helps you to get stronger. You want to add intensity as you get stronger and move more and stretch more. See, these are some of the benefits of physical activity. Can help you to sleep better, less anxiety, helps your blood pressure, and has a variety of long-term benefits. How to keep a healthy weight. So you want to know your BMI, which is your weight relative to your height. And an optimal BMI is less than 25. And you can calculate that easily on the internet. Just put in BMI calculator. It's your weight in kilograms and your height in meters squared, but you can put it in pounds and inches. You want to read food labels so you know about calories, increase the amount of fiber you eat and water, add protein for breakfast, which helps you feel full longer. Definitely avoid fast food and read nutrition labels. Smoking, definitely an important thing to consider to reduce your risk for cardiovascular disease and cancer, of course. Benefits of quitting is after 1 year of quitting, you halve your risk for heart disease. And there are many ways now to get help with smoking cessation. There are various medications and programs. If you call 1-800-QUIT-NOW, you can get some support for smoking cessation. And then we used to have 7 factors that the American Heart Association recommends. Now there are 8 because they added sleep. So getting a good night's sleep every night is vital to your health and brain, to your heart and brain health. So adults should aim for an average of 7 to 9 hours. I doubt many of you are getting that many hours of sleep. And this helps with brain function, improved mood and energy, stronger immune system, healing of and repairing of cells, tissues, and blood vessels, and less risk for heart disease. There is this epidemic of obesity now in our country. This is a map that shows the prevalence of obesity, a BMI greater than 30, and you can see it varies significantly by state. But in 2024, at least 1 in 4 adults in the US had obesity. And unfortunately, there are persistent and pervasive health inequities in the United States. So the highest age-adjusted cardiovascular death rate was in Mississippi, and the lowest was in Massachusetts. There are also very significant inequities by race and ethnicity, with the highest age-adjusted cardiovascular death rate being in non-Hispanic Blacks among males and non-Hispanic Blacks females among the females. There's a lot of research, a lot of this that I'm involved in with my team, trying to understand what we can address to try to reduce these very important inequities in our country. Also, we spoke briefly about women and heart disease. We're planning another whole program about women and heart disease, so stay tuned for that. I mentioned women tend to get heart disease 10 years later than men, generally after menopause. We generally don't recommend hormone therapy to reduce risk for heart disease, although taking the lowest dose possible to control perimenopausal symptoms is generally acceptable and something you need to talk about with your care providers. Cardiovascular disease is the #1 cause of death in women, and the American Heart Association has this campaign called Go Red for Women, which helps to raise awareness for heart disease in women. And there are a lot of reasons why women don't take action against heart disease. They think it's just a man's disease. They don't make health a top priority. They think they're not old enough to be at risk. They feel too busy to make changes in their lives, and they're already feeling stressed and they're tired. So the red dress is the national symbol for women and heart disease awareness. I like this cartoon. It says, to prevent a heart attack, take 1 aspirin a day, take it out for a jog, then take it to the gym, and then take it for a bike ride. So again, emphasizing the importance of exercise, but we no longer use aspirin in people who don't have heart disease to prevent a heart attack. We learned from a number of recent clinical trials that the risks of bleeding from aspirin, especially as we get older, outweigh any potential benefits in preventing heart disease. So we have been stopping aspirin, and especially in our older patients who were taking it to prevent heart disease. Whereas people who have known heart disease, especially if they've had a heart attack or they have a stent in a heart artery, they need to be on aspirin. So it's the difference between whether you have known heart disease or not. Another area of great interest among our research group is measures of what we call subclinical atherosclerosis. This is an image of a coronary artery calcium scan, which is a CAT scan of the heart, which is a CAT scan is an X-ray, and it doesn't involve any contrast injection, but you can see whether there's calcification in the heart arteries. And whenever there's calcium, that means there's atherosclerosis or plaque. And we can compare how much atherosclerosis and plaque you have by your calcium score compared to other men or women your age to see what your risk for developing heart disease is. And you want your artery to look like this instead of like that. So that is a very quick, brief overview of preventive cardiology and life's essential 8. So health behaviors, you want to eat better, you want to be more active, quit smoking if you do, get healthy sleep, manage your weight, control your cholesterol, manage your blood sugar, and manage your blood pressure. And again, go online, read about Life's Essential 8. There's a lot of information. I didn't have a lot of time to go into a lot of detail, but a lot to learn what you can do to help reduce your risk for cardiovascular disease. So thank you very much for attending today, and I hope that you all learned something. So we now have our Q&A. And so to ask a question, type your question into the Q&A box and click send. If you want to send anonymously, you don't want your name attached to your question, you can do that. Alternatively, you can email us questions and also provide feedback at hopkinsseminars@jhmi.edu. And you'll get a request to complete our survey. So a pop-up window will appear at the end of our presentation. Please answer the survey. It really helps us when we plan our future presentations. And if anyone's looking for more specific advice about how to reduce your risk for cardiovascular disease or any cardiology appointment, this is the phone number for cardiology scheduling at Johns Hopkins, 443-997-0270. As I mentioned at the beginning, the group that I work with is the Ciccarone Center for the Prevention of Cardiovascular Disease, and there are many physicians in the group who can provide expert guidance on helping you to reduce your risk for cardiovascular disease, or if you already have heart disease, working with you to reduce your risk for further heart problems. So we're now going to transition to the questions and answers. So let's see. Can you talk about what an ideal calcium score is? What should someone do if they find out they have a high score? So that's a great question. So I only mentioned coronary calcium briefly. I could do a whole talk just about coronary artery calcium. That's a lot about what we do our research on. So an ideal score is 0. And the amount of calcium you have is strongly associated with age. So generally when we do scans on younger people, we're more likely to see a 0 score. But if you're an older person, then you most likely will have some coronary calcium. But we have a research database which we use to compare how much calcium you have to other people who are your age and sex. So if you're a 45-year-old man and you have mild coronary calcification, then you might be at high risk, even though it's a mild score because you're young. Whereas if you're an older individual, you might have moderate calcification that might be average for your age, But we still will want to treat you aggressively to try to reduce your risk. So if you have a high calcium score, we use that to determine how aggressively to treat you. We might use a lower LDL cholesterol goal, might help to get you motivated to do more with lifestyle modification. But we don't use that to evaluate whether you need a cardiac catheterization. And we generally don't do stress tests in people who don't have any symptoms. Our salt substitute are salt substitutes you recommend? Um, I generally don't know details about specific salt substitutes. I mentioned that there are recent studies showing the value of a salt substitute that has potassium in it. You have to be careful if you have kidney disease, but if you have a healthy kidney, then healthy kidneys, then using a salt substitute can be beneficial. I tend to tell my patients to just use spices. So, add garlic or pepper or other healthy spices that make your food taste better without having to add salt or sodium. Can you reverse calcification? So if you have a high calcium score, then that's just a marker of how much atherosclerosis or plaque you have. There's plaque that's non-calcified and plaque that's calcified. You can't generally reverse the calcification. What you reverse is the non-calcified plaque. So getting your LDL cholesterol down real low, generally using statin medications, helps to stabilize the plaque, helps to prevent that plaque rupture that we talked about that can lead to a blood clot forming and help to prevent a heart attack. And it helps to reduce the non-calcified plaque, which is the part of the plaque that tends to become unstable. If you were told to start a statin, are you on it for life? Well, generally, unless you make pretty dramatic changes. So some people are able to lose a significant amount of weight or start exercising, changing their diet, and can get their cholesterol down to a healthy level. But most often I find that even with lifestyle modification, once depending on what your LDL goal is and how far you are from your goal, you might need to stay on a statin. But if you lose a lot of weight, then maybe the dose can be reduced. And sometimes the statin can be discontinued. More often, if you lose weight and exercise, you can reduce your blood pressure medications. And often we see people who lose a lot of weight, they start getting lightheaded because their blood pressure is low, because weight loss and exercise is a really great way to lower blood pressure. Let's see here. When you talked about symptoms to get checked for, how long should you wait if you experience any of those? Well, it kind of depends on what your risk is. If you have a lot of cardiovascular risk factors and you develop symptoms that you haven't had before, then you want to take that seriously. So especially if you have chest discomfort that's occurring at rest and is accompanied by nausea or vomiting or sweating or lightheadedness, then you definitely want to go right to an emergency room. You want to call 911. But often, there's all different kinds of chest pain you can have. Like I said, it's not generally like a sharp stabbing pain that just lasts for a few seconds. That's generally not coming from your heart. But if you're not sure, you should go get checked. Are there specific ways to reduce MI risk as a postmenopausal woman? So as I mentioned, hopefully we'll have one of these seminars specifically about women and cardiovascular disease. As we go through menopause, there are changes that occur, as you know. There are changes in cholesterol, changes in your weight, sometimes in your mood and your fatigue and ability to exercise. So, the best way to reduce your risk when you're postmenopausal is to follow those life's essential 8. We don't recommend hormone therapy to lower risk for cardiovascular disease in women. So it's really the same essential 8 that I talked about here will help to lower risk in postmenopausal women. What do you think about supplements like red yeast? So red yeast is a natural form of statin medication. So if you take red yeast, you're taking what's called Mevacor. It was an old statin that we used to use years ago, or lovastatin, and there's really no reason to be taking something like that instead of an FDA approved statin. It's not any safer just because it's natural. If anything, I would say it's less safe because you don't know exactly what dose you're getting. Um, each bottle of it might be slightly different. It's not regulated or tested, and you don't know what additional ingredients might be in it. So I strongly discourage supplements such as red yeast. There are other supplements that say they lower cholesterol. There was a randomized trial that was presented recently at one of the scientific meetings where they gave people various supplements and didn't tell them which ones they're getting. And they looked at the cholesterol numbers, and for almost all of them, the cholesterol numbers didn't change. If you take fish oil, it will help to lower your triglycerides. But generally, fish oil has not been proven to reduce risk for heart disease. But we do use fish oil in people who have very high triglycerides, because if you have very high triglycerides, then that can increase the risk for pancreatitis. But we generally recommend people eat fish, especially fatty fish, such as tuna. Let's see, what is the relationship between liver damage and high LDL? So there's an entity called MASH. We call it fatty liver, where fat can deposit in your liver and it can cause abnormal liver function tests, the AST and the ALT. And that's due to inflammation that's occurring in the liver as a result of the fat deposition. And sometimes the fatty liver can actually even progress to fibrosis and even cirrhosis in really severe cases. And it's generally related to obesity. And so trying to, again, follow Life's Essential 8 will help to reduce your risk for developing fatty liver and progression to cirrhosis. When discussing healthy diet options, you mentioned low-fat dairy. I've read and heard that low-fat dairy is unhealthy for hormones, especially for women. So there's a push now by the federal government to advocate people drinking whole milk. Um, this is not endorsed by the American Heart Association. We don't recommend that people eat a diet high in saturated fat. We recommend low saturated fat diet. I agree with the latest recommendations to limit processed foods. So you want to try to, or ultra processed foods, you want to try to eat food that is not packaged, it's not processed, and cook the food yourself so you know exactly what's in it. But we generally recommend staying away from foods that are high in saturated fat. I'm not really sure about the hormones part. Sorry about that. Is fluctuation in blood pressure reading a cause for concern? So as we get older, our blood pressure tends to become more and more variable. And that's related to what I mentioned about the blood vessels getting stiffer as we age. And so as you get older, your blood pressure tends to be more variable. And one way to limit that is to measure your blood pressure in the correct way. And I talked briefly about making sure that you've been sitting for at least 5 minutes in a quiet room, not talking, and check your blood pressure, at that time, and that should lead to less variability. But it's not generally a cause for concern, so to speak, but you do want your blood pressure generally to be well controlled, which will be generally less than 130/80 and ideally less than 120/80. Sometimes people who are treated to less than 120/80 might get lightheaded, in which case we'll decrease the dosages of medications. But the lowest risk for heart attack and stroke is if you have your blood pressure less than 120/80. Should everyone see a cardiologist, or can my primary care physician manage my blood pressure and cholesterol? So it depends on if you're having any complicated issues with your blood pressure. Sometimes people have blood pressure that's very difficult to control. And we have a physician in our group, Oscar Singolani, who specializes in hypertension. And so if you're having very difficult to control hypertension, he would be a good person to see because he specializes in that. Generally, a primary care physician can manage your blood pressure and your cholesterol. Depending on who the primary care physician is, I think we tend to be a little bit more aggressive with treating blood pressure and cholesterol and giving a little bit more time to giving you specific advice for lifestyle modification, depending on how busy your primary care physician practices. We also have a team of nurse practitioners and physician's assistants who can also meet with you and go over your diet and exercise routine in more detail. Any recommendations to reduce PVCs? So PVCs are extra heartbeats that originate from the ventricle or the bottom pumping chamber of the heart. That's sort of a different topic of arrhythmias. PVCs sometimes can cause palpitations, which can be uncomfortable. There are various ways to reduce PVCs. Sometimes people find that they can be triggered by alcohol or caffeine, so trying to limit your alcohol or caffeine intake. Some women who are premenopausal find that they're associated with the menstrual cycle. But I think PVCs, it just varies as to what your trigger is. And sometimes medication can help if you are very symptomatic. Is high protein bad for my cholesterol? So there are different kinds of protein. So you want to eat healthy proteins that are generally low in saturated fat. So you can eat a higher protein diet as long as it's lower in saturated fat. So that would mean avoiding generally like beef, steak, definitely avoiding fast food, and having smaller portions. So generally we say that your protein serving should be the size of your fist. So most of my patients have trouble with portion sizes. Many are eating the right foods, but just eating too much of it. So it's not necessarily bad for your cholesterol unless it's causing you to gain weight or it has a lot of saturated fat in it. The most healthy animal-based protein is generally fish, but you can also eat low, chicken that's low in saturated fat, especially the white meat more than the dark meat. The skin has a lot of fat in it as well. And if you are vegetarian or vegan, then getting your protein through soy is a very healthy way also to manage your cholesterol. Does good oral hygiene contribute to good heart health, or is it the other way around? So there are studies that show that people who have plaque on their teeth, which is different than the plaque in your heart arteries, have inflammation in their gums, and that inflammation is associated with heart disease. There are a few different issues with that. One is also related to the risk for endocarditis, which is an infection in the heart valves. So if you have poor oral hygiene, that increases the risk of getting bacteria in your blood. And when you have bacteria in your blood, that can sometimes cause an infection if you have an abnormal heart valve. There's lots of good reasons to have good oral hygiene, but there's an association between plaque on the teeth and heart disease. It's not exactly clear whether it's causal or whether it's just an association. If I have low blood pressure, should I increase my salt intake? So some people follow a very low sodium diet, even though they don't have high blood pressure, and they end up getting low blood pressure enough that they're lightheaded or even passing out. And so some people are told to increase their salt intake in order to prevent low blood pressure, especially if they have lightheadedness or passing out. So if you have low blood pressure, depending on how you want to define that, and you don't have any symptoms from it, then that's fine. You want your blood pressure to be less than 120 over 80, and if it's 105 and you're feeling good, then that's fine. But I do tell people to make sure they stay well hydrated, because especially if it's a really warm day, like hard to think about now here in Baltimore, kind of looking forward to that. But as you know, sometimes it can get really hot and humid in Baltimore. And you want to make sure that if you have low blood pressure, that you stay very well hydrated when you go out in warm weather, and especially if you need to be standing for a long period of time. Um, if you had gestational high blood pressure, preeclampsia, eclampsia, during pregnancy, are you more at risk for heart disease? So that's a great question. And again, we'll have another session about women and heart disease. But yes, if you had high blood pressure, especially preeclampsia or eclampsia during pregnancy, you are at increased risk for heart disease. And that is definitely a reason why you should be potentially seeing a cardiologist or seeing a really good primary care physician to make sure that your blood pressure is very well controlled and that you're following life's essential 8 to reduce your risk for cardiovascular disease. Do you have recommended exercise that are healthy and safe for adults over 70? So everyone is different as to what they're able to do with exercise. So you want to make sure that you're safe and that you're not at risk for falling or injuring your joints, or, if you have heart disease, you don't want to push it to the point where you're at risk for injuring yourself. So I think it's best to start out slow. You want to do both aerobic exercise and resistance training. So aerobic exercise, if you're over 70 and you're not used to exercising, then starting out just by taking walks is really helpful. It's good to count your steps, whether you have, a watch that you're wearing or another device that counts your steps. You want to aim for at least 5,000 steps a day and hopefully 10,000 steps a day. And that can be achieved throughout the day. You don't have to go out and do all that all at once. So starting out by walking, you want to walk briskly if you can, gradually increase how fast you're walking, how long you're walking, or if you have the ability to go to a gym, then, or have the equipment at home using a treadmill, an elliptical, a stationary bicycle. Those are all forms of aerobic exercise that are really healthy. But especially as we get older, it's also really important to do resistance training or strength training. If you belong to a gym, sometimes they give you a few personal training sessions for free. It's really important to make sure if you're using the equipment in the gym that you're using it correctly so that you don't injure yourself. And again, you start slow, gradually increase, and that helps to build your strength and your endurance, but also can be effective at lowering blood pressure and helping you to lose weight. Swimming, great exercise. I go to a swim class every Sunday. It's good, especially for people who have orthopedic issues. It's not as good for osteoporosis because it's not weight bearing, but swimming is a great form of aerobic and resistance exercise. Are Apple Watch and AFib monitors accurate? So the Apple Watch is pretty good. It's definitely not perfect. So there are different kinds of things you can get from the Apple Watch. It might just say you're in AFib, but the other thing you want to do is you want to actually record the EKG tracing. And if you don't know how to do that, you can read about it online, but you have to hit the little squiggly that looks like an EKG, and then you hold on to the buttons for 30 seconds, and it'll record an EKG. That way, your physician can look at the tracing to see whether you actually have atrial fibrillation or not. Sometimes people with extra heartbeats, like premature atrial contractions, can be misdiagnosed as having atrial fibrillation. AFib monitors are very similar, and they're generally pretty accurate, but not perfect. You mentioned statins can increase glucose. How should that be handled? So the best way to minimize that, not always easy, but exercise more, lose weight, and try to minimize the increase in glucose. The increase in glucose tends to be with the more potent statins and at the highest dosages, But again, it tends to be a very small increase in glucose. And even though may increase glucose in some people, it's still so clear from randomized trials that it reduces the risk for cardiovascular disease. Um, how to address high calcium scores non-invasively. Again, Life's Essential 8, mostly getting the LDL cholesterol down really low is the best way to reduce your risk for cardiovascular disease. Someone's asking about EECP, enhanced external counterpulsation therapy for atherosclerosis. That's a therapy that's used for people generally who have angina that can't be treated well with routine medical therapies. I think it's variably successful. For some people, it might work. I haven't seen too many people use it recently, honestly. I think that is most of the questions. So it is 5:57. So I again thank you all. Oh, someone says if you have a very high HDL, is this good or could it be a potential problem? So I said HDL is generally preventive. Well, observational studies show that people who have high levels of HDL cholesterol are at lower risk for heart disease. But there are some studies that show that people who have very high levels of HDL might have what we call dysfunctional HDL and maybe at increased risk for coronary disease. And so what we sometimes do in that situation is a coronary artery calcium scan. We generally do a calcium scan in people where it's a little bit unclear what their risk is and how aggressively to treat them. So we don't do calcium scans in people who are very low risk. And people who are very high risk, we don't do it because we already know we want to treat them very aggressively. And speak to studies including women. That's a little vague, but uh, there are most therapies that we use that are effective in men are effective in women, but we haven't necessarily always proven that it reduces risk in women because sometimes the women in the study don't have as many heart attacks as the men. But we're trying to understand more about differences between men and women and what therapies might be more effective in either women or men. And let's see, there's more here. Oh, weight loss drugs. Surprised nobody asked about that. So the GLP-1 receptor agonists are extraordinary drugs that not only help people to lose weight, but also reduce risk for heart disease. So if you have generally a body mass index above 27 and multiple risk factors for cardiovascular disease, you might be eligible, but some insurance companies don't cover it. So it's just a matter of which insurance you have, but they suppress your appetite and make it easier for you to limit your caloric intake. So they help people to lose weight and also reduce risk for cardiovascular disease. So thank you all for joining today. Please remember to fill out the survey, and there's an email address on the screen if they have additional questions. And hope you all have a wonderful evening. Thank you very much.